All right, so Unit 8, this is your shock, and we're going to talk about multiple types of shock. So, what is shock? It is the inability of the heart to meet the body's demands for oxygenated blood, and it could be due to a variety of reasons. We may have talked about shock previously, but ultimately, it is the lack of oxygenated blood getting to the tissues. It is going to affect multiple organs, multiple tissues, pretty much the whole body. So, our types of shock, we have hypovolemia or hypovolemic shock, where we don't have enough fluid or enough blood pumping. Cardiogenic means that it is from the heart. Something is going on with the heart that is not pumping out the blood. Obstructive means that the heart is either not filling, there's an obstruction, or it's not ejecting blood out to the body. Distributive is an umbrella term that we use, and it covers septic shock and anaphylactic shock. Both of these are going to have major excessive vasodilation. And we have excess vasodilation that's going to impair the blood flow and the oxygen getting to the tissues. So, what is mean arterial pressure? Why do we have to know it? We have to have pressure in our vessels so that we get blood flow going to our tissues and the oxygen goes to the cells that we need to keep us alive. So, how do we calculate mean arterial pressure? That's your systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. Now we have great tools that we don't have to necessarily calculate that for ourselves now, but you should still know it. A normal map, your book says 60 to 70. I strongly encourage it to be above 70 because once you get down to 65, we really start to worry about the organs being perfused. So if less than 60, that is going to be your priority patient. That means that they're not perfusing those vital organs. And your MAP, your mean arterial pressure, is dependent on total blood volume, cardiac output, and our vessels. So if we have good blood volume, good cardiac output, and good constriction and vasodilation, both good pressures in our vessels, then our mean arterial pressure goes up. If we have dehydration, poor cardiac output, and lots of vasodilation in our vessels, our mean arterial pressure goes down. So hypovolemic shock. This is a patient that is severely dehydrated or maybe they're hemorrhaging out. Ultimately, there's not enough fluid in the body, not enough volume in the body. The tank is empty. So dehydration is due to fluid not being in the vascular space, and there's all kinds of reasons for dehydration. Maybe they're not drinking, maybe they're really, really sick. Or let's consider your cirrhosis patient that has hypoalbuminemia. We need albumin so that fluid gets pulled back into the vessel or pushed into the cell. So that the fluid is not sitting in that interstitial space. So if we do not have fluid or albumin, we have fluid sitting in that interstitial space. I like to consider that interstitial space like an airport. Nothing should be sitting there for long. It either needs to be going to the cell or into the vessel. Just like at the airport, we should not be living at the airport. We are either going to get on a plane or we're going to go home. So we need that albumin to kind of push the fluid to make us have fluid in our vessel. And if we don't have fluid in our vessel, we are dehydrated. It could also be due to bleeding out. So if we have a lack of plasma, we're going to give IV fluids. If we have a lack of blood, we are going to give blood. Just remember, blood and plasma, you only give normal saline for those fluids. Now some risk factors, kind of the out-of-the-box thinking other than the dehydration and the hemorrhaging. Diuretic therapy, our clotting factors are messed up, so maybe they're hemophilia, maybe they're on anticoagulation therapy, therapy and maybe they're taking too much of it. Maybe they have diabetes insipidus. Maybe they have an ulcer somewhere, like in their stomach, and now it's perforated and they're bleeding out. Kind of think outside the box. And then there's that liver disease where they don't have enough albumin. So recognizing those signs and symptoms of hypovolemic shock. You don't have enough fluid. Your tissues are not getting oxygen. So your heart's going to say, I'm going to speed up. I'm going to get faster because I got to get this oxygen to the tissues. The problem is there's no blood flow through there. There's not enough fluid to pump to the tissues. You're going to see a decreased mean arterial pressure. So you're going to be vasodilated, hypotensive, weak peripheral pulses, narrowing pulse pressure. Now, pulse pressure is the systolic versus the diastolic. So when it's narrow, like a normal blood pressure, 120/80. And if we have a narrow pulse pressure, it is going to be like 100/90. We do not want it to be too close or too far apart, too wide. That just means that the heart's not pumping or relaxing appropriately. And then we also have a decreased oxygen saturation. Think about it. You don't have fluid pumping to your organs to get that oxygenated so that your cells stay alive. So oxygen saturation is decreased. So our priorities for hypovolemic shock: give oxygen, put them in a modified Trundleberg position. This is going to help blood flow get back to those vital organs. And a modified Trundleberg means that you're just elevating the feet so that you're getting the fluid back to the trunk area. Do not lower the head of the bed. Just elevate the feet. We are also going to restore the fluid volume. So that could be IV fluids, blood transfusions. We're going to be looking for any kind of wound that is causing massive bleeding. So pressure dressing may be warranted. Assess your neural status because the brain is also not getting oxygen. And do not leave your patient. That is priority. Do not leave them. Now moving into cardiogenic shock. We know that something is wrong with the heart. It's cardio, and the whole reason they're in shock is because of the heart. So the pump is broken. Reasons that this could happen, or risk factors that this could happen. Maybe they have a heart attack, or maybe they have VFib. Maybe they have cardiomyopathies, myocardial degeneration, or heart failure. Maybe they have cardiac tamponade. Remember, tamponade is where that fluid is accumulating in that pericardial sac, and ultimately it's going to squeeze the heart so no blood is going in or out of the heart. Ultimately, that's going to lead to poor perfusion to the tissues. So let's look at the overview. Cardiogenic starts at the heart. You're going to see low blood pressure. The vessels are going to go wide open, thinking I'll make it easier for the heart to get the blood out. But the problem is the heart's broken. You're going to see rapid breathing, or tachypnea, tachycardia. We want to maintain that oxygen saturation. And just remember, the heart is compromised. It could be the heart is in failure, or it could be a myocardial infarction. You need to let the heart rest. You need to put them on a telemonitor. Monitor for those PVCs or any kind of dysrhythmia. So we know the heart is the issue with this shock. So think about if your heart's not pumping, what kind of signs and symptoms are you going to have? Well, your heart muscle is definitely not getting oxygen. So there's going to be lots of chest pain. It could be dysrhythmias, tachycardia with PVCs, clammy skin, increased respirations, decreased oxygen saturation, and then hypotension. But also think about where that blood may be. That blood could be backing up into the lungs because it's not being pumped out. So you might hear some crackles and wheezes. Now, our nursing priorities. Assess your ABGs. Put your patient on a telemonitor, EKG monitor. Place them on oxygen. Raise the head of the bed. So with your hypovolemic shock, you're putting them in a Trundleberg. With cardiogenic, you're raising the head of the bed, making it easier for the heart to get the blood out of the heart. Frequent reassessment. Prepare the client for an echo. So the echo is an ultrasound of the heart, and that's going to help you diagnose if it is cardiogenic in origin or if there's something wrong with the neurons. Is the heart are the valves opening? Is the heart pumping the way that it should? Echo is a very useful tool. Medical management, we're not giving them fluids. Withhold those IV fluids. It is not a fluid level issue. It is the heart's broken. Dublotamine, digoxin. So these both are going to increase the heart rate, but also help with contractility. You're going to assess for chest pain, monitor for hypotension, and if they do have hypertension, that means that we've given too much of those drugs. We're going to decrease that anxiety, increase contractility with the drugs, and decrease the workload and oxygen demand. So kind of help the heart out, get that blood pumping. Now, obstructive shock. So some part of your heart is, maybe there's an occlusion somewhere. Maybe the blood can't get into the heart. Maybe the blood can't get out of the heart. So blood flow through the heart is blocked ultimately. It's obstructed. So that's going to impede circulation. Interference with ventricular filling or interference with ventricular emptying. What are our risk factors? Look at your tamponade, your cardiac tamponade, where the heart's being squeezed and the blood cannot flow through. Arterial stenosis, the vessels maybe the blood can't get out. Pulmonary emboli, a clot. Pulmonary hypertension, maybe there's too much pressure in the lungs and the blood is not flowing into the ventricle appropriately. Constrictive pericarditis. Pericarditis is the inflammation of that pericardial sac, and then it can start to constrict on the heart, leading to a tamponade. We can see tumors, tension pneumothorax, especially when we start to see the deviation of that mediastinum. That means the heart's also moving over. And then an aortic dissection. Blood is not pumping to the heart or flowing back into the heart. Now, recognizing the signs and symptoms of obstructive shock. So, remember, there's an obstruction in the heart somewhere. Blood's not flowing into the heart or out of the heart. So ultimately, there's going to be decreased cardiac output. Is there a clot somewhere? In what lab do we pull to find out if there's a clotting issue? If there's too many clots or if there's a potential to make a clot. That's your D-dimer. We can see central venous pressure increased, SVR increased, shortness of breath, hypotension. Remember, those vessels are going to open wide up, saying, I'm going to make it easier for you, heart, to get that blood out. But the problem is their blood's not pumping effectively in the heart because there's an obstruction. You could hear muffled heart sounds, tracheal deviation. Think about your tamponade. So muffled heart sounds, jugular vein distension, pulsus paradoxus. Think about your pulmonary, where the air is building up. Not an embolism, a pneumothorax, sorry. So pneumothorax, tracheal deviation from the midline. You can also see decreased urine output leading to kidney failure. That would be like a heart attack patient, but think more on the lines of there's a clot and there's an obstruction causing that heart attack. So blood flow is not going to the kidney. Therefore, the kidney starts to get injured and goes into a failure or injury. Fatigue, diaphoresis, and decreased peripheral pulses. So your nursing priorities. Monitor for decreased cardiac output by assessing signs of decreased tissue perfusion. How do we know? By looking at our patient that our patient is not being perfused. Their color, how they feel, like when you touch them, are they cold, are they hot? Are they modeling? When you look at their toes and you touch them, is there good cap refill? And then look at their vital signs or look at their neural status. when you look at vital signs, you're going to see tachycardia, maybe not. At first with this, you'll see tachycardia, but as the heart continues to be obstructed, it's just going to go put on you. Then you have neural status. They're not getting oxygen to the brain, so altered mental status, level of consciousness decrease. So stop and think, what else have we discussed that's had this issue? Organ works, but not enough fluid getting through to be effective. So that's going to be your pulmonary embolism, your pulmonary hypertension. Fluid to it is fine, but organ itself is not working. So we are able to perfuse all day until it gets back up to the heart and nothing can go in because the heart's being squeezed with that cardiac tamponade. Fluid is fine, organ itself is fine, but there's a blockage afterward. So maybe there is arterial stenosis. Maybe there is aortic dissection somewhere. And then distributive shock. So fluid shift out of the vessel. This is remember this is the umbrella term for anaphylaxis and your sepsis, or neurogenic is another one. We will lightly touch on neurogenic. We are going to talk about that with our spine too. So massive vasodilation, sepsis, and anaphylaxis. So, SIRS alert. We hear this a lot, especially in the ER or on acute, like PCU units. A SIRS alert is abnormal. It has to have 2 abnormal parameters of the 4. So, body temperature, heart rate, respiratory rate, or white blood cell. So, if your patient comes in with an elevated temp and an elevated respiratory rate, that's going to send off a SIRS alert, hopefully. I'm not too great with Meditech, but I know Cerner and Epic automatically bring up an alert for the patient if you click on that patient's name. And it's kind of like you can't go around it until you hit that you're aware and you're doing something about it. Neurogenic shock you have with a spinal cord injury. Remember, when we hear the word genic, that means the origin, and the word that comes before that is what is causing the problem. So spinal cord injury, a neural issue. And then we have anaphylactic shock. Etiologies of distributed shock. So, neural induced, you could have pain, anesthesia, stress, spinal cord injury, or head trauma. Chemical induced is going to be anaphylaxis, sepsis, a capillary leak, burns, excessive trauma, liver impairment, or hypoproteinemia. So what is the cause really? So anaphylaxis, we know that it is more of an allergic reaction. Neurogenic is injury to the spine, so spinal cord injury. Septic shock is a systemic reaction from inflammation. Now, I hope you guys remember the cytokines. Those cytokines, especially, like, think about that acute respiratory distress syndrome. When there is injury or a severe infection in our body can overreact sometimes. And how does it do it? We get those cytokines. The cytokines are like the people on the loud microphone calling their troops in, saying it's time to battle. So the cytokines are sending out all these alerts to the white blood cells. Now, when we get too many cytokines, too many alerts, everything gets congested. Not only that, but when those cytokines are sending out those alerts, they are vasodilating your vessels so that the white blood cells can get to the area. So recognizing your signs and symptoms of distributed shock. Tachycardia is going to be initial. Decreased mean arterial pressure. This is massive vasodilation, so their arterial pressures are going to be low. Weak peripheral pulses. Decreased oxygen saturation. Remember, they're vasodilated, so they're not getting good blood flow to their organs. Increased heart rate, which we already said, tachycardia. Cool, pale extremities, decreased level of consciousness, and confusion. So important monitoring, oxygen perfusion, and cardiac monitor. Your anaphylactic shock. So that's your chemical induced shock. It is a massive allergic reaction, causes massive release of histamine. So when we talk about histamine, it comes from that mast cell, just like all of your chemical components that cause an immune reaction. Histamine gets released with your cytokines, your bradykinins, all of these chemicals get released. Ultimately, it is alerting your immune system saying, hey, there's something foreign here and we need to attack it. We need that immune system to come out. So histamine is going to vasodilate your body so that your immune system can react to what it thinks as being foreign. Now, remember, some people's bodies are overreactive. So if you have a patient and they have anaphylactic shock, that means that their immune system is hyperactive. And it could be hyperactive over a food, like peanuts is a very common one. The body just thinks that the proteins in the peanuts are a foreign body or a bacteria and it needs to go right away. So we get that massive vasodilation. You get all these immune mediators like histamine, cytokines, all of them come out to play. And all of a sudden, all that vasodilation, so all those white blood cells can get to the site, drops our oxygen to our tissues. So you'll see that massive vasodilation. It does have a rapid onset. Some things that you will see in your patient, they're going to have swelling, bronchospasms. They could have feelings of apprehension, like that impending doom. So neuro-induced or your neurogenic shock. This is not chemical induced. Remember, it is neuro induced. It's a disruption in the communication pathways between upper and lower motor neurons. Neurogenic shock can occur in clients who have a severe spinal cord injury above T6, and it is going to occur within 24 hours after that injury. You are going to see dilation of blood vessels leading to decreased perfusion to those vital body organs. So no perfusion. Safety priority for this or your critical response, monitor the patient with acute spinal cord injury at least hourly for neurogenic shock. Remember, a T6 spinal cord injury, 24 hours, they are at risk for that neurogenic shock. You're going to monitor them hourly. Things that you will see, temperature dysregulation, including warm, flushed skin, bradycardia, level of consciousness decreases, decreased urinary output, a systolic blood pressure less than 90, a mean arterial pressure less than 60. You're going to be monitoring them, all their vital signs, their respiratory status, their neuro status every hour, and calling the rapid response team immediately if you notice any changes. Just remember, hopefully we talked about spinal shock in class. It is not the same as neurogenic shock. So neurogenic shock occurs within 24 hours. It is most common in injuries at that above T6. It is life-threatening. It happens within that first 24 hours. It is a disruption in communication of the motor neurons, ultimately leading to massive vasodilation. So your risk factors. Neurogenic shock is a critical condition that occurs when the autonomic nervous system is dysregulated, meaning that you've injured it and maybe severed something, and now there is miscommunication between the upper and the lower motor neurons. It is a spinal cord injury. Less common causes could include spinal anesthesia, Guillain-Barré syndrome, toxins that affect the autonomic nervous system, transverse myelitis, and neuropathies. So, when do we call the doc? Or when does the patient call the doc? Ultimately, when do we call the doc? With your neurogenic shock. So, hypotension, systolic less than 90, and MAP less than 65. A decreased heart rate, that they're starting to be symptomatic, loss of sensation, and movement. If we do not take care of that, it's going to be permanent. Decreased level of consciousness and decreased urine output. You're monitoring that patient hourly. Your stages of shock. So you have your initial stage, you have your compensation stage, you have your progressive stage, and you have your refractory stage. So the initial stage of shock is that initial injury or initial infection or being exposed to that allergen you're allergic to. Your compensation, so your body, that next stage is non-progressive. The body is trying to compensate. It provides these mechanisms to maintain perfusion to the vital organs. So you could see an increase in antidiuretic hormone. You could see an increase of renin. Any of those hormones that are going to cause fluid to be where it's supposed to be, and some vasoconstriction. Decreased pulse pressures, increased heart rate, get the blood pumping to with those vital organs. And then your progressive stage, anaerobic metabolism, increased lactic acid. So, massive vasodilation, the body tried to compensate, however, it did not succeed. So what happens? Your tissues are not getting oxygen. Ultimately, they are going to start to die off. When your cells die off in the apoptose, everything in it, all the toxins that are the cellular byproducts, are also going to be released. And that includes your lactic acid. So think about having too much lactic acid. What does that result in? You're going to see the kidneys start to go in overload or not even work anymore. You're going to have metabolic acidosis. You're going to see your lungs start to compensate. Then it goes to the refractory stage. This is irreversible and likely going to end up in multi-system organ failure and death. So your initial stages of shock. Early signs, you'll have low blood pressure and an increased heart rate. When you get to that compensation stage, you're going to see our body trying to compensate. Maybe it's going to start to release antidiuretic hormone. Maybe it's going to start to vasoconstrict with the renin-angiotensin. Maybe the heart rate's going to increase more. Maybe it's going to lower the pH. Progressive signs. Tissue hypoxia, the cells die off, the extremities get cold, you're going to see lactic acid being released. And then refractory is where everything starts to fail and the patient is high risk for death. I would even say high risk. They're more than likely going to pass away. Baseline MAP, so initial stage of shock. Baseline mean arterial pressure is decreased by 10. So we see things starting to drop, some hypotension, some vasodilation. We're going to see a slight increase in diastolic blood pressure, that narrowing pulse pressure. Increased heart rate and respirations. The heart is going to try and compensate, and so are the lungs. You're going to say, your body's going to say, I need more oxygen to my tissues. Unfortunately, it can't get there. Compensatory mechanisms control blood flow to the vital organs. You're going to see decreased cap refill, cool extremities. And then anaerobic metabolism. So lactic acid is produced. You're going to monitor for metabolic acidosis. So you look for hypotension, thready pulses, and the Kussmaul's breathing. Now the second stage, compensation stage, the map continues to decrease. So in the initial stage, it decreased by 10. The second stage, is going to decrease even further, so 10 to 15. You will see vasoconstriction. So the body is starting to release that renin. It's going to start to vasoconstrict. Your heart is still going to be beating pretty fast because it's saying, I need to get oxygen to my tissues. So you will see heart contractility increase. However, it can lead to hypotension over time. Everything gets tired. The body is going to shunt blood from the skin, kidneys, and GI tract. So just like with anything, we need to perfuse our vital organs before anything else. So results in cool, clammy skin, hypoactive bowel sounds, and decreased urine output. You're going to see hypothermia. They're cooled. Perfusion of tissues is inadequate. Your body is trying to keep your vital organs alive at this point. However, it's not going to work too well if we don't correct it. So acidosis is going to occur because of that anaerobic metabolism. Cells are dying off. You get a release of lactic acid, and your potassium is also going to increase. Respiratory rate's going to increase because of the acidosis. Your saturations are going to be 95 or 90%. Confusion may occur. Sodium and glucose levels are also going to be elevated in the response to aldosterone and catecholamines being released. When your body is super stressed out, it is going to release these catecholamines, such as epinephrine, dopamine, all of that stuff, and ultimately try to keep your heart going, that fight or flight response. It is also going to start to release stored glucose. So this is why you see sometimes patients that are in the ICU, they're not diabetic, but they're on insulin. It's because of that stressful physiologic state that the body is in, trying to keep those cells alive. And it's releasing all of this stuff, cortisol being one of them. So sugars are being increased to help keep those cells alive. Aldosterone is also going to be released to help with fluid status, and along with that comes the salt. Now, the third stage, progressive stage of shock. Mechanisms that regulate blood pressure can no longer compensate. So your BP and your MAP decrease. When your blood pressure drops, damage has been done on a cellular level. So the tissues, your body's just pretty much giving up at this point. It is tired. It has nothing more to give. So this patient needs the medical team to take care of the body, really. The patient can no longer... So sorry. So your body is tired, and your medical team needs to provide all the support that it can for the body to regain some control. So all organs are suffering from the hypoperfusion. Vasoconstriction can continue to occur. However, remember, at this point, blood pressure is dropping. There is no good perfusion. Mental status further deteriorates. So level of consciousness is going to be decreased. Likely the patient's going to be in a coma at this point. You're going to see decreased cerebral perfusion and hypoxia. Sludging of blood in the capillary beds occur. Oxygen utilization by cells becomes impossible. There is the sludge, the blood is not carrying the oxygen appropriately, and it can't get to the sites appropriately. So you're going to see more of your cells die off. The body's going to stop using oxygen, anaerobic metabolism with your acidosis, hyperkalemia, tissue ischemia, all of that's going to occur. So metabolic acidosis is going to be a big concern. Your saturations, O2 sats, are going to be down to 75%. Now, the last stage, refractory stage of shock. This is the irreversible stage. Not going to make it, unfortunately. So diffuse lack of cellular oxygen seems to initiate this phase. Multi-system organ damage is so severe that the client does not respond to treatment at this point and are not going to survive. Blood pressure remains low, renal and liver functions continue to fail, anaerobic metabolism continues to increase. Remember, when they get to a point of acidosis where their blood pH is so acidic, they will die. You cannot live with a blood pH less than 6.9. I would even say 7 sometimes. Multiple organ dysfunction progresses to complete organ failure. Mortality is about 100% when 3 or more organ systems fail, and we need to consider end-of-life care. So, all types of shock, some things that are important to remember. Early identification and timely treatment is important. We want to keep our patients' organs perfused and alive. So we need to treat early. Identify and treat the underlying cause. Is it because they're hypovolemic? Is it because they have myocardial infarction? Is it because they ate shellfish and they're allergic to shellfish? Is it because they have a cardiac tamponade? We have to figure out what caused it and how we're going to fix it. The sequence of events for the different types of shock will vary. Therefore, the management and the care of the client will also vary. So, one thing's for sure, we're going to monitor that oxygen. Make sure in their map, make sure that they have the ability to have oxygen to the tissues and that their map stays above 70, hopefully. Your nursing alert: by the time the blood pressure drops, damage has already been done at the cellular and tissue level. Clients who are at risk for shock must be assessed and monitored closely. We monitor closely every hour, if not sooner. You're elderly in shock, beta blockers are going to be dangerous with this because it's going to hide the fact that the heart is trying to pump faster. So tachycardia, remember your SIRS alert, you have to have 2 of those things, and your heart rate is one of them, respiratory rate is one of them, temperature, white blood cells. But beta blockers affect your heart rate and sometimes even your respiratory rate. They slow things down. And then always remember confusion, change of level of consciousness. We kind of just think our old people are demented almost all the time, and that's not a true story. So if your elderly patient is confused, we don't consider that normal. Nursing management of all types of shock. So, continuous client assessment. Monitor oxygen, perfusion, pain and anxiety, and have them on a telemonitor. IV access is really important. Think about having just one peripheral access, and maybe they're really hypovolemic, or maybe they're having a myocardial infarction, and you're trying to push fluids through that one peripheral access, and all of a sudden that access blows. Well, you are likely not going to get another access, so make sure that you have multi-lumen central line available as soon as possible, that you at first maybe have multiple lines. So that if you lose access in one, you can have the other one until you get that central line. Observe and assess clients for changes in level of consciousness, their vital signs, their pulse pressure. Remember, shock, they're going to have that narrowing pulse pressure a lot of times, urinary output, and their cap refill. H2 blockers or PPIs are going to be important. Remember that physiologic stress on the body, the release of the cortisol, those H2 blockers or the PPIs are going to protect them. But I like to put in another caveat with this, especially for your anaphylaxis. Histamine release. The H2 blockers are going to help block that histamine release, which causes that massive vasodilation. You're going to look at their skin. It's going to be, is it cool to touch? Is it a different color? Are they sweating? What's happening? Their lab values, especially their ABGs, their white blood cells, and their red blood cells, the hematocrit and the hemoglobin. And then don't forget your liver and kidney function. Priority nursing focus is monitoring tissue perfusion and oxygenation. Now, vasoactive medications, all types of shock. When fluid therapy alone does not maintain your mean arterial pressure, utilize meds that help increase cardiac output and contractility. That's your nitroprusside, your dobutamine, and your norepinephrine. So if we are giving them fluids and we're not seeing any changes, we need to work on our heart, getting it having better contractility so it's pumping the oxygenated blood out. We give those through a central line. We're never going to stop them abruptly, and doses are going to be titrated to how the client is responding. So complications of shock. Disseminated intravascular coagulation. So we talked about this a lot so far this quarter. Always remember that this is a clotting issue. They use up all their clotting factors, and then they have these little microclots everywhere, and then they are also a high risk for bleeding out everywhere. So a condition in which small blood clots develop throughout the bloodstream. You get those microclots, they're going to block those small vessels and cause a lot of problems. And then, so you use up all your clotting factors, and now you have none, so now you have excessive bleeding. Our treatment is supportive care, monitoring our platelets, giving them fresh frozen plasma. They will need some heparin to break up those microclots. Monitoring their temperature, bathing daily, but be careful that you're not using those strong soaps with them. We can also do platelet transfusions. You don't see that as much, only in the ICU really, but the goal is to break up those clots and to also replace some clotting factors. So complications of shock could also be septic shock. So when there's an infection or an injury, cells are going to produce those cytokines. So we kind of remember this as your distributive shock, right? You get that vasodilation. This is why I save septic shock for this area, because your septic shock could be a complication of all types of shock. And this is why we do our SIRS alerts. So when we have an infection or an injury to the body, we get the production of those cytokines. And sometimes our body is hyper-responsive and produces too much. It's going to also produce everything else that is going to alert our immune system to activate. So histamine is one of them. It's going to open up the vessels and allow for plasma to escape and allow for our white blood cells and everything get to the site to kind of protect the body. But in this scenario, it is overprotection to the point that it's doing damage. So plasma contains those white blood cells and fibrin to assist with injury or infection. So think about your sinuses and breathing. When you breathe in cat dander, this is how your body makes that drainage. So you get all of that vasodilation and the stuffy nose, and then the mucus production, because you got lots of white blood cells going to the site. You get the histamine response, you get the plasmas leaking with all the white blood cells, which causes the mucus production, and then bam, you can't breathe. In this case, the infection with your septic shock is systemic. So histamine is floating everywhere and the vessels are opening wide open everywhere, causing massive third spacing. So when you widen everything up, things are going to start to leak out into that interstitial space. We never want too much leaking out into that interstitial space because sometimes it's not where it's supposed to be, but also when it gets into that space, it doesn't go anywhere, it just sits there. And we never want anything sitting in the airport. Remember that interstitial space is like the airport. We must get fluid back into the vessel and stop the infection. We have to also stop the histamine release. At the same time as the arteries are opening, the veins are constricting. So imagine stopping on a nail. Your veins in your foot constrict to keep germs in the foot away from the organs. Your arteries are going to open and pull in the area to kind of get the white blood cells to where they're supposed to go to protect you. But we don't want the bacteria going further into our body, so our veins vasoconstrict. In this case, these actions are happening all over. What happens when blood is trapped? You get venous constriction and microclots. So you get these little microclots everywhere. You get massive vasodilation in your arteries. You get constriction in your veins. Everything is going haywire at this point. So septic shock, quick overview. Severe edema, leaky blood vessels, microclots. It is all due to an immune response that is releasing all of these cytokines, histamines, all these things that are alerting your white blood cells, your plasma cells to get to the site to take care of that foreign body that's not necessarily there. So your arteries are dilated, your vein and your capillaries are constricted. Clots are going to form. Poor perfusion. Things are going into the third space and getting stuck there. So you have severe edema. Now, remember your SIRS alert, your septic shock alert. You have 2 or more changes in body temp, heart rate, respiratory rate, white blood cells. Pick any of those 2, and if they're irregular, it's going to send off a SIRS alert, hopefully. So how do we treat it? We are going to fluid resuscitate. Remember, the fluid is not in the vessel. It is third spacing. We're going to do blood cultures. Is it because they have a bacterial infection? Why did their immune system become so overreactive? We're going to put 2 large bore IVs in. Start them on broad spectrum antibiotics until we figure out what the culprit is. We're going to lactic acid monitor. Remember, we're not perfusing our tissues at this point. The fluid's in that third space. The arteries are vasodilated. The veins are vasoconstricted. So your cells are going to die off. And when your cells die off, it leaks out all the byproducts, the lactic acid. And what does that cause? Metabolic acidosis. We're going to have strict I's and O's, cardiac monitoring. Is it the heart that caused the septic shock? Or is it the lactic acid and the high potassium causing cardiac issues? And we're also going to do blood glucose monitoring. Remember, when your body is in a severe physiologic stressful state, you get the increase in glucose from the cortisol and the release of your catecholamines. Ultimately trying to feed your cell to keep it alive, but sometimes it doesn't do too good. Sometimes it's too much, so we might need to put them on insulin. So this is just an example of your sepsis criteria, and most hospitals in their EMR will send off an alert, hopefully, and you can't bypass it until you sign saying, I am aware that this patient has these abnormal findings and I have looked at them. So, local infection, systemic infection, early sepsis, SIRS alert, or your systemic inflammatory response syndrome, and then organ failure, and then death. We worry about, that's why we have those SIRS alert, to kind of protect. So SIRS alert, remember the temp, heart rate, respiratory rate, blood cells. Any of those 4 are going to be, you got to pick 2 of them, and if they're abnormal, it's going to set off the alert. If our patient has 2 SIRS alerts, we're automatically assuming they have sepsis. We are going to start pulling our cultures and doing all the workup for them. If they're sepsis positive, we're going to hopefully prevent organ damage from all that edema, third spacing, lack of perfusion to the tissues. Look for hypotension, a systolic less than 90, a narrowing pulse pressure, a lactate greater than 4. That means the cells are dying off. And then septic shock, severe sepsis with persistent signs of organ damage, persistent hypotension, and a lactic acid buildup. So, your systemic inflammatory syndrome, or your SIRS. Prior to a full-blown sepsis, the patient will have SIRS. It is manifested by a CO2 less than 32, but they're breathing out all their CO2 because they have metabolic acidosis. They have a temp greater than 100.4 or less than 96.8. Their heart rate is more than 90. They become tachycardic. Respiratory rate greater than 20. They're tachypnea. White blood cells greater than 12,000 or less than 4,000. Your blood pressure is systolic less than 90. Your diastolic may be increasing. Your MAP less than 70. Urine output is going to start to decrease, especially within the 2 hours, despite giving fluids, because the fluid is not in the vessel. Your body's thinking it's dehydrated, so it is holding on to the fluid. An INR greater than 1.5, so high bleeding risk. Absent bowel sounds. Remember, we're perfusing our vital organs. Our GI tract is not considered a vital organ. It's important, but it's not going to keep us alive in that dying moment. Platelets less than 100,000, so high bleeding risk. Elevated lactic acid, elevated potassium, decreased cap refill. So our criteria: body temp, irregular, heart rate, irregular, respiratory rate, heart rate and respiratory rate are high. Leukocyte count is either high or low. Now, other complications of your shock: multiple organ dysfunction syndrome, or your MODS. It is a progression of shock. It is altered organ function that requires medical intervention. We actually saw this quite a bit with our COVID when things got really severe. High mortality rate, increased heart rate, increased cardiac contractility and output, increase oxygen consumption. You're going to see an increase in those catecholamines, cortisol, antidiuretic hormone, and glucagon. Your sugars are going to be high. So treatment: maintain that perfusion, give them oxygen and organ support. So this is a progressive stage of shock. It is life-threatening. Vital organs tolerate this situation for only a short time. The less oxygen that they're getting, the more likely they're going to be dying off and causing organ dysfunction. Immediate interventions are needed to reverse the effects of this stage of shock. So you have to be quick in response to any little change to that patient. You have to correct it within an hour or less. Otherwise, organs are dying off. And when you have multiple organs dying off, that patient's likelihood of living is not good. And then you're going to find out what the culprit is and hopefully fix it. So questions. The nurse has received handoff report for a group of assigned clients. Which of the following clients should the nurse see first? It is a client currently on a ventilator, a client going into cardiogenic shock, a client with a low blood sugar, mental status change, or severe peripheral edema. So the answer is D, patient with a mental status change. For some reason, I have here on a ventilator. I would even say cardiogenic shock should be first, but I didn't make this question. So I would actually say it would be a client in cardiogenic shock, client with mental status change. If they're on a ventilator, yeah, you should be checking them, but they're not going to be your priority. You would also see severe peripheral edema, low blood sugar. All of those are pretty bad. Honestly, though, if it was me answering the question, I would pick cardiogenic shock over all of them. And then, of course, mental status change. The nurse is caring for a 17-year-old client who is involved in a motor vehicle crash and is in the refractory stage of shock. Which of the following actions would be appropriate for the nurse to take? So we know that refractory stage of shock means that there's no coming back. It's irreversible. Their cells have died off, organ damage has been done, and their likelihood for living is not good. It's actually pretty high that they're going to die. So, recommend the case manager that they're going to go to an LTAC facility. No, they're not going to go to the LTAC facility. Determine if the family would like to spend time at the client's bedside. Absolutely. That's probably the last time that they're going to see their loved one. Monitor the client's urine output every 15 minutes. They're no longer peeing. Use lactated ringers or ringers lactate when administering a prescribed unit of packed red blood cells. No, you give normal saline with your red blood cells. So that's wrong. So the only right answer here is family at bedside. Remember, their likelihood for dying is 100% at the refractory stage. The nurse is caring for a client who recently underwent an abdominal aortic aneurysm repair. Which of the following assessment findings would suggest that the client is in the initial early stage of hypovolemic shock? So a decrease in the client's mean arterial pressure of 20 from baseline. So remember, the initial stage of shock, the MAP drops by 10, not 20. So that one is wrong. A change in pupillary response to light from 4 to 6. No. Decrease in respiratory rate from 28 to 14. That's normal. That is a good thing. Might be too much, just depending on how fast it did it. An increase in client's heart rate from 80 to 107 beats per minute. So normal to abnormal. We're going to pick this one. Remember, tachycardia is in that initial stage. And just some pictures for you guys to look at. Make sure that you guys are doing the questions that I have posted. And if you have any questions, please reach out to me. And I will see you in class. Bye.